Welcome to this upskilling session again on pregnancy and childbirth. This one is just talking about pregnancy and childbirth, and it's here more of a recap. It's more of a recap really before we get into the other stuff for you guys to just, I suppose, refresh your memory on what it's all about. There's quite a bit in some of the slide sets. So this here, pregnancy and childbirth. So pregnancy related emergencies. So this session will look at revising the emergencies themselves. We're going to talk about pregnancy and related terminology because there's a significant amount of stuff in here that we do forget. The anatomy physiology we're going to talk about, pre-hospital emergency childbirth, just a normal childbirth, newborn neonate care and resource, and some new CPGs for 21 and changes from 2017. Some of these are going to be repeated in the next lecture, which is involving issues to do with childbirth. We're going to talk about them again. So this is a warm-up session if you want. So some terminology. So obstetrics is the branch of medicine that deals with the management of women during pregnancy, childbirth and up to 6 weeks afterwards. Okay, that's what obstetrics is. Gestation is the length of time in days or weeks that a baby is in the uterus itself. Parity, so when you talk about parity, it's the number of times a woman has given birth to a child. So that's irrespective of the outcome. So irrespective of if the child lived or died, if a lady had 4 births and 2 were live births and 2 did not survive, she still had parity 4 times. So nullipara, never given birth, multipara, given birth more than once. Okay. So gravida, number of times a woman has been pregnant regardless of the outcome. A uterus is the womb where the child obviously grows. Cervix is the narrow lower end of the uterus that softens and opens during labour to allow the baby to actually exit the vagina. Embryo is an egg given to a fertilised egg from the time of conception until the 8th week. After the 8th week, the embryo becomes a fetus. Umbilical cord is the conduit, so it's the lifeline that connects the actual fetus itself to the placenta. The placenta embeds itself within the uterine wall, and this is the interface between the mother and the actual child itself. It has 2 arteries and 1 vein through which respiratory gases, nutrients and waste pass. So it's the lifeline that allows fuel and oxygen to get into the child and allows all the waste products to come back out. Placenta is the organ that connects to the wall of the uterus. It nourishes the baby through the umbilical cord itself. The amniotic sac, which is the bag which the child actually grows in. So it's a bag-like membrane within which the fetus develops within amniotic fluid. So the child actually resides within the amniotic fluid as it grows, and the fluid is contained within the sac. The liquid that surrounds the baby in the uterus is also called the waters. The perineum is the area between the vagina and the anus, which may tear during birth. Pre-hospital, you're limited to providing gentle pressure against the infant's head to prevent an explosive birth. An explosive birth may literally rip that tissue apart, and it causes major issue for the mom later on. Antepartum hemorrhage is bleeding from the vagina during pregnancy. It's quite common during pregnancy to have small spotting or even small amounts of blood to actually leak out. Postpartum hemorrhage is loss of greater than half a litre of blood after birth. So this will be something that will challenge the mom's life potentially and put her into shock. Labour is the process of childbirth from the start of uterine contractions to the actual delivery itself of both the child and the placenta. The trimester is a time span of 3 months during pregnancy, so it's broken into 3 trimesters. So the first, second and third trimester, the first trimester the embryo predominantly resides within the actual pelvis itself. The second trimester is normally up as far as the umbilicus, and the third trimester tends to be all the way up as far as the diaphragm. So premature, a baby is born before 37 weeks gestation, they're considered to be premature. And a neonate is a newborn less than or equal to 4 weeks. So here's a bit of a cheap cartoon-like picture. You can see here the uterus itself, the cervix, which has to open to facilitate birth of the child through the vagina. The pubis of symphysis is the front of the actual pubic bone itself, the vagina, and the perineum is the space between the actual the rectum and the vagina itself. So here we have a placenta which embeds itself on the uterine wall. An umbilical cord connects the placenta to the actual child's umbilicus. We have the amniotic cavity, the uterus itself, the lumen of the uterus, And within this, here we have the amniotic sac in which the child is there within the actual waters themselves. So the physiology of pregnancy. So a woman is born with all of her oocytes or eggs, which she will ever release. They're already sitting in situ. An oocyte matures into an ovum each month due to the presence of various hormones, and the ovum enters the uterus via the fallopian tubes, where it is fertilized. So they're always fertilized within the fallopian tubes. The inner lining of the uterus itself, the endometrium, increases in size and secretes the materials in which the fertilized eggs will actually embed itself and grow. Cell division increases rapidly, eventually generating the fetal membrane, placenta and embryo. And once implanted in the uterus itself, the woman will undergo huge physiological, hormonal and chemical changes literally within a couple of days, and certainly within a couple of weeks. By the second week after conception, the amniotic sac, umbilical cord and placenta, they're all being formed. At 8 weeks, you can actually see the fetus itself there. You can see eyes, you can see limbs. You can see the sac itself is already formed. At 18 weeks, you can see the child all of the structures are in situ, all the structures are in place. At 24 weeks, that's a viable child. That child can actually survive. So maternal changes by the end of pregnancy, the uterus itself may weigh up to 1 kilo and have a capacity of 5 litres. Like that's pretty significant. The blood volume increases by up to 50%. At term, the uterus contains 15% of the mother's blood volume. Remember, it's like sticking an extension on your house, if you want to think of it like that. We have to heat it, we have to feed it, we have to keep it warm. We've huge blood flow in and out of the actual uterus itself. The heart rate increases 15 to 20 beats by term. So, a woman at rest will have a resting heart rate of probably 80, 90 beats per minute, because she has extra blood volume and she has, extra space in which to pump blood. So the pump speed itself needs to go up. Because of the extra volume, the pressure itself will be dropped. So although we could see heart rates up by 20 or 30 beats a minute at rest, we normally see resting blood pressure is actually lower, particularly in the third trimester. Cardiac output increases by up to 40% at term. So there's major changes. It's a huge load. It's a huge load on the woman to carry the child at term. Blood pressure is generally lower during gestation, except for those who are hypertensive or borderline hypertensive. These people may have preeclampsia. Uterine enlargement from 20 weeks can compress the inferior vena cava, which can decrease the return of blood to the heart. As a result, healthy pregnancy patients in a supine position or prolonged standing can experience symptoms of hypertension. So, once they're moving into the kind of third trimester, they really don't want to be standing for long periods. And if they're, sitting down, it's nice if they can lie down, just to promote venous return. This can be prevented by tilting the patient to the left, so left lateral tilt on either an immobilization device or by placing padding under the right buttock. So if we actually need to transport somebody for whatever reason, and they're pregnant, and it may be nothing to do with the pregnancy itself, for sheer volume of comfort, we may lie them on their left side. We can prop them up with pillows. If they are on the likes of a spinal immobilization device of some sort, or in the likes of a vacuum mattress, we can pad it so we have a bit of a left lateral tilt. And again, this just promotes venous return. There's a huge load on the woman's cardiovascular system. High blood pressure, hypertension. Pregnancy-induced hypertension may develop after the 20th week. It may be a sign of preeclampsia. And elevated pressures of greater than 140 on 90. Protein in the urine, proteinuria, with or without edema, usually presents after 20 weeks, but it can occur up to 6 weeks post-birth. So again, it can actually present after birth. It also may present with severe headache, visual disturbances, difficulty breathing or vomiting, and it may lead to eclampsia, which is characterized by seizures. Seizures themselves, again, will induce hypoxia in the mom, and again, I suppose by default, hypoxia in the actual fetus itself. Eclampsia is life-threatening tonic-clonic convulsions, occasionally followed by coma. Generally occurs in the third trimester. 60% of cases reported while giving birth or within the first 48 hours post-birth. So around birth time is when we really lift the pressures up, or just afterwards, and this is when they're really prone to seizing. Major cause of death in pregnant women in underdeveloped countries, and a risk of maternal and fetal hypoxia and placental abruption as a result of seizures. Okay. Gestational diabetes is very common. Those predisposed to diabetes may develop gestational diabetes, as cellular sensitivity to insulin declines. So the cells become less sensitive to insulin due to the presence of estrogen. Estrogen blunts the actual action of insulin and opening up cells to allow sugar in. Progesterone decreases the utilization of insulin by the cells. And again, progesterone and estrogen are big pregnancy hormones. Fetal demand for glucose increases. When the child is growing, they need fuel. Blood sugar levels become too high because inadequate levels of insulin. So sugar is not being taken into the cells, and blood sugars actually rise. The condition is treatable and usually disappears after pregnancy. Very treatable with a strict diet. And in general, to look at the studies and look at the evidence, women who are treated with strict diets actually look really, really healthy during pregnancy. Ectopics. So a fertilized ovum becomes implanted normally somewhere outside of the actual womb itself, and normally it's in the fallopian tubes. The majority of these pregnancies are not viable and they will never come to term. Severe abdominal pain may radiate to the tip of the shoulder, usually between 4 to 6 weeks. Urgent transport to hospital. This is an emergency. This is a serious emergency, an acute emergency. So this is ectopic pregnancies. Miscarriages themselves characterized by vaginal bleeding with abdominal discomfort or menstrual-like cramps. And again, depending on what trimester of pregnancy will dictate how heavy the bleeds can be. Be alert for signs of shock and treat for same. Raise the legs, keep them warm, give them oxygen. All pregnant patients with perivaginal bleeding or abdominal pain should be transported to obstetric units. Absolutely. If causation of PV bleeds is traumatic, transport to an ED. But anything that's non-traumatic needs to go to the actual obstetric department. Assessment. So, all assessments of pregnant women, there's a number of questions we need to ask. So, pregnant, are you pregnant? The number of prior pregnancies. And when we talk about women being pregnant, all females between the ages of kind of 12 to 40 are pregnant until proven otherwise. The number of prior pregnancies, gravida. Number of deliveries, parity. How many weeks pregnant? When is her due date? Are you due now? So, are we, is the pregnancy to term? Is it before term? Is there any bleeding, spotting? If there is, how much? Have our waters broken? And if they have, what colour are they? Are they green? If they're green, we may very well have meconium in them. So the child may be in distress and have defecated within the actual waters themselves. This can lead to respiratory compromise up the road. Is there crowning? So is there signs of crowning? The child is actually going to arrive, because if there's crowning, then the birth is imminent. So these are things we need to know about. When did the pain start? So how long ago? How hard is the pain? So are the pains regular? Because if they're irregular, it's probably not labour. If they're less than 2 minutes apart, and again, that's from the start of one contraction to the start of the next one. Are they increasing in frequency and strength? Normally, if they're getting stronger and are becoming a little more frequent, we tend to know that the patient is in labour. Does she feel the need to move her bowels or to push? And if she does, that's normally that'll be a good time to kind of have a look and make sure that there's no crowning present. Have there been any problems with this pregnancy or any prior pregnancies? Is there just one child here? Is there the potential for twins or triplets? We need to know these things. Here we go. If there's more than one child in situ, then one of them will most likely be breech. One of them will be feet first. Has the mother any underlying health problems? So HIV, hepatitis, bloodborne stuff, or has she got any other stuff, the likes of preeclampsia or high blood pressure, diabetes? We need to know about these things, because these are all risk factors for both the mom and the child. Has the mother any health issues you need to know about, IV drug use, seizures, anything like that? So here's the CPG, and it's going to rear itself up again on a subsequent slide set that we're going to talk about. So pregnancy related emergencies. Again, here's to determine gestation, parity, single or multiple. We're asking all the questions that we need to ask. Clinical assessment, are they in labour? Either they are or they aren't. Strong regular pains, then they are. We go to the childbirth CPG. If they're not, consider left lateral tilt if it's after 20 weeks, just to facilitate blood flow back into the heart. Rapid assessment of the home environment, report at handover. Vomiting in pregnancy, again, our colleagues, or paramedic or advanced paramedic colleagues may give some medications for that. 20 to 40 weeks with a headache, visual disturbance, difficulty breathing, edema or seizure, measure the BP. If it's more than 140/90 and we've two of them 15 minutes apart, then this lady is preeclamptic, and again, advanced life support will be very, very beneficial to this patient. Okay. Eclamptic seizure, pre-eclamptic suspected, yes. ALS, no. We're going to pre-alert their concerns to a general ED. Primary complaint of PV bleeding, apply a pad. Recent trauma, yes. We're going to the general ED. No, we're going to the obstetric unit. Pre-alert if there's pain, pressures up or down, if there's an issue with shock, if there's a low presenting placenta, shoulder tip pain or sepsis. Again, the appropriate CPG, and we'll be popping her to the obstetric unit. So again, this is just making it big, what we've talked about. So this is our history, clinical assessment, childbirth CPG, no. Left lateral tilt if she's greater than 20 weeks. We're going to promote blood flow back through that inferior vena cava. Rapid assessment of the home environment, and we can report at handover. So vomiting or pregnancy, again, our paramedic or AP colleagues will sort them out, and we'll be transporting to the general ED. Greater than 20 weeks to 40 weeks, so, third trimester or thereabouts. Headache, visual disturbance, dyspnea, edema or seizure, we're thinking about pre-eclampsia. We'll be checking pressures. Again, 2 pressures, 15 minutes apart, greater than 140 on 90. We need to be looking for our advanced life support colleagues. Again, if we're not expecting eclampsia, we'll be going to the general ED. Primary complaint of a vaginal bleed, we'll apply a pad. If there's recent trauma, they'll be going to the ED with a pre-alert. If there's no trauma, it's medical. We'll be popping her to the obstetric unit, and we'll be pre-alerting them if there's serious pain, high or low blood pressure, concerns of shock, a low-lying placenta, shoulder tip pain or sepsis. And that's that CPG. Labour itself and delivery. We'll have a look at this. So there's a short video on this, 2 minutes or thereabouts.
During a vaginal childbirth, the first stage of labor lasts about 12 to 19 hours and starts when your baby settles lower into your pelvis. In response, your cervix begins to efface or become thinner and dilate or widen. During this time, you may feel strong, regular contractions occurring every 5 to 20 minutes and lower back pain and cramping that doesn't go away. You may see a brownish or reddish mucus discharge, which could be the mucus plug at the opening of your cervix, falling out. Your water may break, which can either be a large gush of fluid or a continuous trickle. If you experience any of these symptoms, contact your doctor or midwife to see if you should go to the hospital. At the beginning of stage 2 of labor, which usually lasts from 20 minutes to 2 hours, your cervix is fully dilated to 10 centimeters. And your baby's head has moved beyond the cervical opening into your birth canal. Your doctor or midwife will instruct you to push during your contractions and rest between them. In a normal delivery, your baby's head will rotate to face your back. During active labor, your uterus is divided into an active segment that contracts, pushing the baby downward, and a flexible passive segment that remains relaxed, stretching to provide more room for the baby to pass through. When the top of your baby's head appears, or crowns, your doctor may make a small cut, called an episiotomy, to enlarge the vaginal opening. Then, your doctor or midwife will give you instructions on how to push your baby out. As your baby's head passes through the birth canal, it molds into an elongated shape. An elongated head shape will resolve itself within a few days as the skull bones shift back into place. After your baby's head exits the birth canal, his or her head and shoulders will rotate to help the shoulders pass through the birth canal. Your baby's shoulders are delivered one after the other in order to fit through your pelvis. Once the shoulders emerge, the rest of your baby slides out easily. After your baby is born, his or her umbilical cord will be cut. In stage 3 of labor, which may last 5 to 30 minutes, mild contractions will help push the placenta out of the uterus. During this stage, you and your baby may begin bonding through skin-to-skin contact and breastfeeding.
Okay, so just a quick short video there talking about the stages of labour in it. The first stage, regular contractions, dilation of the cervix. This is where most of the pain happens over a number of hours. The second stage is delivery of the child through the actual birth canal, which you know, once we have full cervical dilation, normally happens pretty quickly. And the third stage is delivery of the actual placenta itself. The stage of labour, nullipara versus multipara. So you know, the first stage for your for a lady who's never had children in general is much longer than a lady who's had children previously. So your first child in general, the labour lasts longer. Second stage, 1 to 2 hours for your first child, 30 minutes for the second one. Third stage, 55 minutes to an hour. It's kind of the same. However, as we have multiple children, as we move forward, and ladies, you know, we're called to people who have had 2 or 3 or 4 children previously. You know, if they're in heavy labour, I'd be very suspicious. I'd be looking to transport them ASAP. In general, labour lasts. They can go from being, you know, 5 or 6 centimetres dilated to be fully dilated and pushing literally within 10-15 minutes. So every labour is different, but in general, if ladies have had births previous, the labour normally goes much faster. Transport decisions, so have the membranes ruptured? You know, what are the number of prior births? I've got, you know, 6 children already. You know, this is probably going to happen pretty quick. What's the distance to the hospital? You know, is it 5 minutes away, or is it, you know, is it an hour on lousy roads? You know, is it 45 minutes across a mountain or something? You know, if that's the case, we probably need to be leaving now. Are there any abnormal presentations? You know, is there a hand or a foot? Have we been, you know, diagnosed with the fact that the child is breech? They haven't turned yet. Are there any other pertinent medical considerations? So they have high blood pressure, they have preeclampsia, they have gestational diabetes, you know, they have seizure disorders. They have something needs to be taken into consideration. We probably need to be, you know, considering going earlier rather than later. Do not attempt to move the mother if the contractions are less than 2 minutes apart. Crowning is present. If crowning is present, the baby birth is imminent. It's going to happen. The mother who has previously delivered tells you the birth is imminent. If she tells you, I'm pushing now, I need to deliver now, then it's going to happen now, irrespective of what you want. So, preparing to deliver a pre-hospital delivery. So preparing to deliver pre-hospital, assemble all the necessary equipment you have. So, you know, your aprons, your masks, your goggles. You know, it's an environment in which the potential for, you know, fluids to be, there's everything flying around. So we need to create as sterile an area as possible. Prepare the area is to be as sterile as possible. Inform the control. You know, you're going to deliver on scene. Request a second crew. Consider ALS. Consider if, you know, if you're in a semi-rural environment, is there a local midwife or a doctor that can help you out? You know, if there is, call for them. They may not be available, but if they are, they may very well help you up the road. So some of the stuff in a maternity pack: a hand towel, 2 pairs of gloves. I normally put on 2 pairs for this stuff, because if we need to take off a pair, we have a clean pair underneath. Quilt, mucus extractor, surgical scissors, umbilical cord clamps, maternity pads, healthcare risk waste bag, aprons, and a polythene bag, absolutely, and some warm water.
Just a minute tutorial. Get
Mum has a very strong urge to push. I have just confirmed full dilatation by vaginal examination, and we can see the head on view. And as the head approaches, the perineum is bulging. We can encourage Mum to push at this point, but as the head advances and we have crowning, we want to slow down the delivery of the head. So we need to use our left hand to maintain flexion of the head and our right hand to guard the perineum, and encourage Mum to pant. And the head's delivered. Just check for chin, and then we await restitution. Once the shoulders rotate, we put our hand each side of the baby's head. Maintain gentle traction, 45 degrees. Deliver the anterior shoulder, followed by the posterior shoulder. Gently lifting upwards and using both hands to catch the baby.
1-minute tutorial.
Okay, so you can see that lady there demonstrating the skill set that was talked about earlier. So pre-hospital emergency childbirth, so this is actually a normal labour itself. Some changes from the 2017 CPGs. So clinical condition entry changed from query labour to in labour. So this is actually a CPG for a lady who's in labour. The sample history, sample sequence step is removed. Patient in labour decision process is removed because they're actually in labour. You're making a clinical decision. New decision process pathway begins with birth imminent. So birth is actually imminent. So this is where we're starting from. Cord complication, malpresentation and risk factors decision process pathway are all sitting there, and it helps us make decisions for moving forward. Risk factors for complicated delivery instruction information box is added, and transport to obstetric unit is added. So birth imminent, yes or no? Yes, request a second crew and maybe request ALS if available. So consider additional crew for each baby expected. Consider advanced life support. Consider analgesia, absolutely. So cord complication, yes, we go to cord complication CPG. No, we have a look. Malpresentation, so is there a limb or something presenting? If there is, we go to that particular CPG, and if there's not, we look at risk factors. So there's risk factors, yes. Initiate rapid transport, pre-alert to labour ward. Optimise resuscitation of the mother and aim for birth in the hospital. That's the big thing. We're looking for a hospital birth if there's risk factors, because the potential for injury to the mom or the child is huge. In the pre-hospital environment, we have no safety net. So risk factors, there's none. Mother to adopt a position of comfort. Prepare the environment and the equipment for birth. So you're going to put pads underneath the mom, put a couple of sheets under her. You're going to make sure that she's comfortable. We're going to make sure that we have all of our sterile equipment to hand, our resuscitation equipment for both mom and for the child, just in case things go astray up the road. Monitor our vital signs and support the baby throughout the actual delivery itself. So, supporting the baby. So the baby themselves, warm, dry, stimulate, check airway, breathing and circulations, clamp and cut the cord. At this stage we can present the baby to mom for skin to skin contact, and the mom's body temperature will thermoregulate the child. The mother herself, check for a second baby, and again we would have done that in the history check, but just to be sure. Our paramedic colleagues can offer some oxytocin. If the mother is stable, we go to our primary survey, secondary survey. Mom is not stable. If she is stable, skin to skin contact with the child. Encourage breastfeeding if there's no contraindications, which will stimulate the release of oxytocin and bring on the birth of the placenta. If the placenta delivers, it goes into a healthcare risk waste bag. We make sure we get all of it and we take it to the hospital with us. So, a couple of information boxes. Wait at least 1 minute post-birth. Clamp the cord at 10, 12 and 15 centimetres, and we will cut the cord between 15 and 20. That way we have two clamps between the baby and the actual cut cord. We have one clamp between the cut cord and mom. Okay. Risk factors are actually listed here. So prematurity, multiple births, vaginal bleeding, preeclampsia indicators, trauma, possible placental abruption, history of anticoagulant use, which will induce a lot of bleeding, history of female genital mutilation, meconium in the actual waters themselves, which is a green staining from fecal defecation within the actual uterus itself, placenta previa or low placenta, a stitch in the actual cervix, or diabetes. Any of these are considered risk factors, and there's a bit of reading on this CPG itself. Newborn neonate care resource, there seems to be a lot going on here. Having a look down the side, there's a little bit on it. We'll look at it in a little bit more detail. Let's have a look at this. So, this new CPG, newborn care and resuscitation. We're going to have a look at this one again in one of the other slide sets. It combines part of the 2017 CPGs, pre-hospital emergency care, childbirth and BLS neonate. So basically what we're doing is we're adding extra things into the 2017 CPG. Post-birth CPG dealing with uncomplicated delivery and care of the newborn and resuscitation of anapnic or bradycardic presentations. Introduction of the Mr. SOPA concept, which we'll mention. Glucose gel administration for EMT if glucose levels are less than 2.6. So there's a couple of little bits in this. So, clamp and cut the cord. We have birth, we're going to clamp and cut the cord. We're going to wait at least a moment, at least 1 minute, and we're going to clamp at 10, 15 and 20 and cut between 15 and 20. as mentioned. Normal tone, breathing and cry, yes. Warm and dry, put a hat on them, skin to skin with the mom, and they can breastfeed, and we'll take it from there. Normal tone, breathing and cry, no. Warm, dry and stimulate. Position the airway and clear any secretions. Apnea, so the child is not breathing, they're gasping, or they have a heart rate less than 100. If they do, it's positive pressure ventilations for 30 seconds, and we're going to do this practically here in the actual training centre as a skill set. So PPV, just a bag and mask, no supplemental oxygen for 30 seconds, and then we'll reassess. So is it effective? Yes. If it's effective, then we're going to warm, dry, blah, 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 blah. If it's not effective, we're going to look at Mr. SOPA, and we'll talk about Mr. SOPA in a moment. Heart rate is greater than 100, yes. If it's less than 100, we're going to do PPV for 30 seconds. Heart rate becomes less than 60, we're into neonate CPR. So we have some stuff on this side. We have a lot of stuff going on the left hand side of the CPG. Pre-alert if preterm or low birth weight, suspected congenital anomaly or pre-identified complication. In other words, if we know from the pregnancy itself there's a problem, we need to pre-alert. Thermoregulation, so optimize the environment and baby factors. Consider an exothermic mattress, fine. Less than 32 weeks, place the torso in a clear bag. If the child is preterm and they're less than 32 weeks, we recommend they go into a polythene bag. A turkey bag is what we would kind of advocate, up as far as the neck. We don't dry them, we pop them straight in the bag, and it's keeping all that heat in there and maintaining body temperature. Oxygen therapy, term infant, FiO2 to 21%, we'll talk about that. Newborn SpO2 targets in the first minute 60 to 65, the second minute 65 to 70. There's a number of specific SpO2 readings here, and that's fine. It's fine in a hospital environment, but it can be quite difficult in a pre-hospital environment these are here for you to understand and have a read of, but I mean, the workload on you will probably be considerable in the first couple of minutes after birth. Mr. SOPA, mask adjustment, reposition the airway. So Mr. SOPA is, am I providing positive pressure, PPVs, positive pressure ventilation for the child, and nothing is improving? If it's not improving, we'll have a look at Mr. SOPA. So we talk about the mask itself. Adjust the mask, I may not have a good seal. Yeah. Reposition the airway. So sometimes the airway needs to sit into the mask. Suction the mouth and nose, open the mouth, increase PEEP, and an alternative airway we'll have a look for. So we're talking about your neonate CPR. Heart rate less than 60, yes. Chest compression, so it's CPR at 3 to 1, so 3 compressions to 1 ventilation. We use the two-hand encircling methods with two thumbs, or we can use 2 fingers on the chest. We're going to talk about this in detail, and we're going to do it practically in the training centre. So in continuous CPR, our ALS colleagues will consider some medications and some fluids. We'll consider blood glucose for 36 to 40 week gestations. We'll have a look at that. And we're going straight to the obstetric unit. There's a little bit in this, and again, we're going to do this one practically. We're talking about if glucose levels are less than 2.6. We're talking about glucose gel, 2 to 4 mils buccal, to just lift the sugars a little bit and give the child a little bit of fuel. Managing temperature, thermoregulation. So pre-alert if preterm or low birth weight suspected congenital anomaly or pre-identified complication. Thermoregulation, optimize the environment. So less than 32 weeks, pop them into a plastic bag up to the neck. What we would advocate would be the likes of a turkey bag. Special instructions which the practitioner must follow. Exothermic mattress, gel-filled, thermostable, disposable mattress that provides up to 2 hours of warming. Preterm infants are prone to hypothermia immediately following birth. Absolutely. As are regular children. Here you go. This is what we're talking about. This is the actual transport warming bag which gives heat for up to 2 hours. If your CPG provider offers you these, then at least you know what they are. There's the child in the bag. And what it does is you can see the child has not been dried or cleaned, and it allows whatever heat the child has to be kept and trapped within the bag there. And it keeps, and you'll see that there's a little hat on the infant as well. So it's all about keeping the temperature in. So they can't generate temperature. So after birth, newborn is exposed to a much, much different environment to what they're used to. So there's a risk of hypothermia. It's very real and very dangerous. So dry, warm and put a hat on the infant. Place skin to skin with a blanket covering the mom and the baby. Adults have responses to cold, so we, vasoconstrict, we get piloerection, our hairs in our arms stand up, we start to shiver, we start to generate heat. Children don't have these actual compensatory mechanisms. Newborns do not possess any of these, they're susceptible to rapid heat loss. Resuscitation nearly always due to a respiratory cause. Yeah, so most of the time it's nothing to do with the actual heart itself. It's been pumping away in there for whatever, 6, 7, 8, 9 months. In general, it's an issue with the respiratory system. During delivery, respiratory exchange is interrupted for, sometimes 60 to 75 seconds in between contractions. Some children really don't tolerate this very well at all. Babies who gasp following delivery they're attempting to correct this hypoxia, and if you can, almost think about PEEPs or positive end expiratory pressure, what they're trying to do is to pop all these alveoli and get them inflated. Remember, they've never been inflated before. Children actually get their oxygen from maternal circulation. They're not actually breathing air until their very, very first breath. They need to pop all these little dome tents in the alveoli and get as many of them up as possible so they can exchange gases for themselves. Newborn lungs are filled with fluid at birth, and crying generates PEEP. It pushes the fluid out. It pops the alveoli, if you want, so they can exchange gases. Okay. Mr. Sopa, apneic, gasping or heart rate less than 100, positive pressure ventilations for 30 seconds, not effective. Why aren't they effective? What can I change? So Mr. Sopa is talking about adjusting the mask, readjusting the airway. Suction the mouth and the nose. It's about getting rid of these secretions. It's just starting the respiratory mechanisms to get gas exchange going. Make sure the mouth is open. Increase pressure on your bag and think about alternative airways. Heart rate greater than 100, yes, post-resuscitation care. Heart rate greater than 100, no, positive pressure ventilation for 30 seconds. We'll go through the algorithm practically, guys. Positive pressure ventilation at 3 to 1, 100% oxygen. So here's a little vid.
If the newborn's heart rate does not rapidly increase after beginning positive pressure ventilation, you must determine if you are providing effective ventilation. Ask your partner if there is perceptible chest expansion when you deliver a breath. If the newborn's heart rate is not improving and you do not see perceptible chest expansion, you need to take corrective action right away. The 6-step corrective action sequence can be easily remembered using the phrase Mr. Sopa. Each letter in this phrase stands for a different step: mask adjustment, reposition airway, suction, open mouth, pressure increase, and alternative airway.
During a vaginal child.
And that's it. It's a pretty simple little concept. And it's designed so that you can remember it. Mask adjustment, reposition the airway. So what I'm doing is not working, so I need to change what I'm doing. Suction the mouth and nose. Open the actual mouth itself. Increase pressure on my bag. So what I may not do is I may not have enough pressure. So I need to increase PEEP. And consider an alternative airway. If you've got advanced life support, they may place in a tracheal tube or an LMA. So blood glucose level, check if it's clinically indicated. So blood glucose levels, so the child is a little bit poorly, seems a little bit lethargic. Sugars are less than 2.6, glucose gel 2 to 4 ml buccally for your EMT. Summary, so you're 27, in addition 4 pregnancy-related CPGs, and the 21 has 6, 4 of which are new. Pregnancy-related emergencies covering vomiting, pre-eclampsia and eclampsia and PV bleeding, new pathways added for treatment, pre-hospital emergency childbirth, uncomplicated deliveries there, newborn care and resuscitation steps for apneic, gasping or heart rate less than 100 and heart rate less than 60. And there's a little bit in it. We're only there to assist. The majority of pre-hospital childbirths happen on their own. I mentioned that to you earlier, but always be prepared, always. There's some references there, and we look forward to doing the practical stuff with this on you guys in the actual centre here.